It's actually 8 hooks. Good afternoon, all dear professors and colleagues. I'm Dr. Essam from Iraq. I need to start my lecture.
No, this is not the presentation.
It's not mine, actually. Essam. It's a video. Yes. No. No.
Put the wrong presentation. Okay, Essam, let us do the last one, and then when you will be ready.
Okay.
Okay.
It's a present.
You can do it directly.
Yes. Me on.
Okay.
Me on final. The video. It's
Done.
just before starting. You need to stop it and start there. So it's a referred case from one of my professors. It's an middle-aged female, high myopic, only eye, having high myopia, dense cataract, and dislocated one with pseudoexfoliation and small pupil, all in one session. I started regular phaco. I put 4 iris hooks to dilate the pupil to see the dislocation. Start the rexes with sharp instrument because it's not easy to puncture the anterior capsule. I go ahead toward the weakest area so that I can have counter traction from the good zonules. I started the rexes from that side, but once I go to the other side, I have no counter traction from zonules, so I put capsular hooks to counter, to provide me with the tractions. On the other side to complete my rexes, so a central circular curvilinear capsular rexes was the target. The 4 hooks, the first 4 are for iris, and the second 2 hooks are for the capsule. But this is not enough. Another 2 hooks are put, but I found that the inferior support is not enough, so I've changed the iris hooks to further support the lens inferiorly. I started phacoemulsification. I do horizontal chop. You need to change the setting. You need to have a good power, but a limited control of your vacuum and the flow rate, so that not disturbing the weak zonules and the weak bag and producing vitreous. I've completed the regular phaco, although it is a dense one and a little bit elastic. Once I'm finishing the phaco, the final pieces, I've found something wrong happening during removal of the last small fragments on the epinuclear shell. 2 things were not happening properly. First, near the phaco probe, I've seen something coming to the phaco probe. The second, the side port, some viscoelastic and maybe vitreous is coming from the side port. So I've paused. I've seen something near my phaco probe. It's coming to me near the phaco probe, so I paused. I've decided to go out. Of course, before going out, we need to put viscoelastic and go out safely. I use my cutter, my manual cutter, because I'm suspecting vitreous on this side. The setting is irrigation aspiration cut, so I'm using the aspiration to remove the cortical material. And once I'm suspecting there is vitreous, I change to position 3 to cut that vitreous. But still, I'm looking for what's has came to my phaco probe while doing the last piece. Still, I'm waiting for it to come, and this is the nightmare that Dr. Ashraf spoke about it. You may see that, whoa, it's a large deciment detachment coming and approaching the center. So you need to complete your surgery without aspirating it, because you may enlarge it and cause further damage to the endothelium. So once I've decided, I've seen that one, I've decided not to fix that dislocated bag. I've decided to take it out and go for scleral fixation. You see that the zonules is almost absent. Once I catch the bag, I can take it out without significant resistance because of the weak zonules. I go for Yamani. I go for direct docking of the needle. This is a PMMA haptic, so I need to be gentle with it. And the first haptic is docked directly with the injection of the IOL. The needle is left in place, and the second haptic is docked to the other side. Once the haptics are externalized and cauterized, now it's time to deal with the decement membrane detachment. Air bubble was put in place to make the fold come back to its position. Then a full thickness corneal sutures were placed to oppose that decement detachment and put it back in its place. Once this is secured, a small PI was done. I always do it, especially in such an only eye patient, to secure. Just see the end of the case. Sorry. So by ending, I've put a PI, just the end of it, to see the last. Yes, last. So again, we put the air bubble to secure the fold back into place. Then the sutures will make sure it is not that small to keep it with only air. So I put even 3 sutures to make sure that this is I will not face post-op decement detachment. PI was done to make sure that there was no pupil block later on post-op. And 2 weeks post-op, the sutures are removed, no decement detachment. Thank you.
Thank you. Yeah, we're gonna move forward to the last one. The pupil snap sign recognizing the